Happy to be here tonight with all of you. And yeah, as Ginny said, did all my training back in Ohio, and I've been out here now in Arizona for about 27 years, I think, maybe a little bit longer than that. Um, and I have been most recently at Midwestern University over in Glendale. About 3 years ago, we decided that we were going to look for an implant system with which we could get better guides. We had been doing actually manufacturing our own guides in-house. So we were pretty familiar with scanning and digital technology, but we just weren't happy with the guides that we were getting. So we started looking for a better solution. The other thing that we really wanted to do was find something that gave us everything that we needed in basically in a box, right? So we finish the plan, we submit everything, and we get a box back that has everything that we need to do that case. And part of the reason we want to do that is because Midwestern, our university teaches strictly pre-doctorate students. We don't have any residency programs on campus. We do have a relationship with the University of Arizona's oral and maxillofacial surgery program, and we do have some rotating residents occasionally. And I do teach over there occasionally, but we don't have any full-time residents. So we're educating dental students on implantology, both the science, the placement, and the restoration of those implants. So I felt that it was incumbent on us to find a system that a relatively inexperienced practitioner could feel comfortable doing. And that's really what we were after. So we started looking and we looked at a lot of different brands, different companies. And one of the things that we noticed that we didn't like is that everything was piecemealed together. So in other words, it'd be an implant company, they would outsource the guide somewhere, and the guide company would outsource parts and pieces and materials from someplace else. And then they would buy their mills and their printers from someplace else. And then they would put it all together. And it was just very inefficient, and we just didn't like the pieces and the parts, and things didn't always go right. So when we heard about DIOnavi and the fact that everything that they do is their own, in other words, they have their own printer that they've developed, they have their own printing material that they've developed, they manufacture their own sleeves. Um, Everything that they do is their own. And so what we found is that the quality of the materials was superior. And we did a lot of comparison. We didn't just go off of what they were telling us. I'm a skeptic by nature, and so every time I started looking at something new, I was having doubts about different things. And I'll kind of talk about a few of those as I go through things tonight. But um, I can tell you that eventually we were satisfied, and they were kind enough to allow us to do 20 trial cases before we introduced it to the university. So myself and one of the other docs in the clinic over a break, we saw 20 patients, and we obtained cone beam CTs ahead of time, and we obtained cone beam CTs postoperatively so that we could compare the workup that we did preoperatively with what we then got postoperatively, and we could overlay those. And I can tell you that we got very accurate results. Not only did the guides fit very well, the results were exactly as we'd planned. So we were pretty happy with it, and we were satisfied to move forward, and we did. And now we place about 500 implants a year. And I can tell you the vast majority of our guides and our implants turn out very nicely. So with that said, I'm going to go ahead and move on with the presentation. And what we wanted to do tonight was some Q&A. So they reached out to all of you and asked you to submit some questions, and I have 10 of those that we're going to go through. That's going to allow us about 5 minutes per question, and that will and a little bit of time at the end too that we can kind of go through some additional follow-up questions. Some are going to be a little longer, some will be a little shorter, but basically it's about 5 minutes. It's kind of like we're speed dating here. So let's go ahead and start with the first one. The first one is, why is there one size tissue punch for all cases? And I'm going to answer this one in a long kind of roundabout way, because we're going to start out with, why do we use a tissue punch at all? Why don't we just flap everything? So I can tell you, I put my first implant in about 31 years ago at Ohio State. and we flapped everything. And I think most people did back then, and even for quite a long time after that. But then, slowly over time, people started looking at doing things flaplessly with tissue punch, biopsy punch, and other things. And there was some research done that started looking at what are the differences between the two. And I think that's one thing that we always need to do as clinicians is to go to the research to kind of support the decisions that we make clinically. So there were four things that this particular experiment looked at. It looked at what is the difference between how the flaps heal, how do the different types affect blood supply, and of course, blood supply affects bone loss or lack of bone loss, and then pocket depth as well. So let's look at each of those. So this experiment was a dog study. And this is a dog mandible, and they put two implants in adjacent to each other, and they did multiple on multiple animals. And you can see that one they did flapless, and that the other they did flapless, and one flapped. Now, keep in mind, of course, that when you do a flap, a lot of the results of that hinge on your surgical skills. How exactly are you performing the surgical procedure? When you do a tissue punch, especially through a guide, that's pretty standard. The punch is the punch, and it's going to go where it's supposed to go. And it doesn't require a lot of hand skill on your part, not only making the incision and raising the flap, but also how you close it. This flap is clearly closed too tightly. It's strangulating the flap. The edges are not approximated properly, and there's a gap here. And when you close that way, it's going to affect your healing. So you can see here now, a week post-operatively, the flapless area looks pretty much identical to what it had looked before. This side, you can see the results of the sutures being a bit too tight. There's a gap here because these edges weren't approximated properly, and so they didn't heal incorrectly. And in some cases, you can even end up with situations like this where your flap can dehiss and then has to heal in by secondary intention. So I think clearly we could all agree that this flapless is going to be a better result than what we could get at times with a flap surgery, especially if you're not an experienced surgeon, which my dental students are not. So for me, knowing that they don't have to raise flaps like this, but they can just use a punch like this, that was very interesting to me. And that was one of the things that really attracted me, was I knew that they could do that and they would get consistently good results with it. What about changing the blood supply? Now the dogs have been euthanized. They've harvested the mandibles. And if you look at the image on the left, this is a soft tissue image. And what we're looking at here are the presence of blood vessels. And you can see the arrows are pointing to several blood vessels on the left side. And if you look at the flapless side, you can see that the blood vessels are a lot more robust. And we're going to look in a second as to why that is. But you can see that there's a lot better blood supply in the flapless slide. What about bone loss? So every time we lay a flap, we are stripping the periosteum off of the bone. Now, the bone gets its blood supply from two places. It gets its blood supply from the periosteum. It also gets its blood supply from the bone marrow. So when we strip the periosteum off the bone, we're interrupting that blood supply for a time, and the bone's strictly getting its blood supply from the marrow, which is enough to keep it from necrosing, but it's not enough to keep it intact. In other words, every time we strip the periosteum, that bone's going to remodel. And when it remodels, it shrinks. We lose bone. And we know that. We know that from many different things that we do when we strip periosteum. But when we're dealing with implants, we just feel like we can't really tolerate that type of bone loss. So you can see on the left, this is a nice image that the authors put in their publication that sort of showed how the blood flow becomes diminished. And in the flapless surgery, the blood flow remains unchanged, which is what we want. So now, like I mentioned, the dogs have been euthanized. And so they've gone ahead and they've uncovered the one side and they placed an abutment. This side, the abutment was placed flaplessly. And then they went back and they stripped the soft tissue off to show you that, in fact, there was more bone loss with their flapped side than what they saw with their flapless side. This is a study from just last year. And it looked at cases over a period of 12 years. And they looked at median bone level changes in millimeters in cases that were done with a flap and cases that were done flapless. And I've got a chart on the next slide that I'll show you that shows that any increase in millimeters above 0 would be a suggestion that there was more bone loss, and it's indicative of bone loss. And if you look at the slide, you'll see that on the y-axis is our bone level change, and the x-axis is either flapped or flapless. Now, the flap side, as you can see, is clearly above 0, indicating that there was more bone loss. The flapless side showed that there was not. So again, just another study to show us that something that we already probably knew from previous studies, but it's good to repeat these studies because it reinforces the information that, in fact, yes, flapless surgery is better. It also affects the pocket depth, or the depth of the sulcus, where the attachment is to the abutment. And in a flapless surgery, we're going to have a more shallow sulcus. Now, we all know that implants have a deeper sulcus than a tooth, even when they're healthy, and we expect that. However, if we can keep that to a minimum, that's always better because that's going to make hygiene easier. This is just a photomicrograph to show you the difference in those attachment levels. Now, back to the original question, why are we only using a 3mm tissue punch for all these different cases? Well, the answer is simple. And again, back to the research. This research looked at different size tissue punches. Again, a dog model, 3mm, 4mm, and 5mm tissue punches. They inserted implant fixtures. Let me see if I can scoot you over a little bit. You can't see the 5mm implant over here, or maybe you can and I can't, but 3mm, 4mm, 5mm implant. And what they saw here on the photomicrographs is pretty impressive. The 3mm tissue punch, this is the bone level. Now here's your implant over here coming down. Here's your plateau, and there's your first thread. So your implant bone level is here. And on your 4mm tissue punch, your bone's down below the first thread. And on your 5mm tissue punch, you can just barely see it there. So again, just another study to show us that a tissue punch as small as possible is going to give us the best results. So here's the real answer to your question. We don't use a 3mm tissue punch for all cases. The 3mm tissue punch is in our master kit. And in the master kit, which we do the bulk of our cases with, that's the 3.8, the 4.0, the 4.55, and 5.5, they all do use the 3.0. The narrows, which is the 3.0 and the 3.3, that's the 2.8. And then our wide bodies, we use a 4.5 tissue punch, okay? And if you have questions about that, we can maybe pick that up at the end, because there's a couple I could think of that you might be wondering about. Okay, the second question was advantages to using multiple drills other than just accuracy. And I think that accuracy is really, you can't be overstated. And really, accuracy and all of these other things sort of go hand in hand, especially primary stability. The way the DIOnavi system is set up, the tolerances within the sleeve, the tube when you use it, and the drills without the tube is so small that they're just not moving in there at all. And so, yes, it is very accurate, but that accuracy leads to very, very high primary stability. That was one of the things I was really surprised about when I first started doing this, especially when we did those 20 cases during our trial, was how high the ISQs are consistently at placement. I just did a case day before yesterday in the maxilla at a number 3, I think it was, or 14. I can't remember which one. And I just needed a couple millimeters of a sinus bump. But the thing that worried me they give us a workup prior to the case, and those of you who use DIOnavi are familiar with it, but it shows you the bone density around the implant. And it was showing me in a lot of areas that I didn't really even have any bony support. And we had seen this on a couple other cases over time. And one of the other guys that I work with, he's wondering, maybe we should do a study on this because we see these cases where this bone is of poor quality, but yet we put the implants in and they seem to be fine. And so I put my implant into this site that at least on the workup looked like there was almost no bone there. Either the patient had severe osteoporosis or it was just really bad type 4 bone. But I put the implant in, I followed the protocol, the drilling protocol, just as it said, and I had 80, 80, 80, and 81 on my ISQs, which I was not, I mean, it's unreal. So that goes back to the accuracy. It goes back to the fact that the tolerances are so small. When that drill's going in and out, it's just not wiggling, right? It's just true every time. And that's what provides us, yes, accuracy, of course, but also good primary stability. So if we want to provisionalize, or if we're doing all on X type procedures where we're going to put our temporary in immediately, you're going to have great primary stability to be able to do that. Also, it decreases the risk of thermal osteonecrosis. How does it do that? Well, again, those of you who use the system, think about those drills. They're very small at the beginning, right, at the tip, and then they slowly get wider as they go up. And each time you go in, and also lengthwise, they only increase in very small increments as you go across your workup. And because they're removing such small amounts of bone each time, because we are using many drills, it's just not enough time and heat to create any kind of osteonecrosis. And I know a lot of times we look at I remember that was another thing when I first went and I was being exposed to this system up in Utah. We went to Heber City. And my buddy and I that I work with walked in and we they had all these kits sitting out on the tables. And we looked at each other and we're like, oh my gosh, what do we need all these kits for? We'd been using a brand for a few years where we had 4 drills, which a lot of you are probably familiar with. And so again, I was being a skeptic. Why do we need all these? This doesn't make any sense. But once you learn the science behind it, it makes a lot of sense. And I can tell you, we've had excellent results with all the ones we've done. So why multiple drills? Yes, accuracy, which, I mean, that can't be overstated. We want accuracy. That's why we're doing a guided system to start with. Improves our primary stability, no doubt. And it does decrease our risk of osteonecrosis. And we know that's probably our number one cause of failure in early implants prior to restoration is heating up the bone. Okay, so here's what I was kind of mentioning before. If you look at the drill, it's narrow here, and then it slowly widens out. And that's what you get here too. And just slow increments so that you're removing bones slowly. And that's going to help us reduce the thermal necrosis. Somebody wanted to know, why should they give up freehand and go to guided? Okay, so I did freehand for a long, long time. We didn't even really have guided surgery when I first started doing implants, even for a long time. And then I slowly started getting into it over time. The first couple that I did were just some single teeth, 2 teeth, 3 teeth. And then I started doing all on 4 stuff with guides and guide reducers. And I really enjoyed it. And I found that it was a lot more accurate, of course, but I found that things were more efficient in how we did it, because I did all on 4s for a while without not guided. We just had some devices that we used that showed us the arch, and that you made sure we didn't go past 30 degrees on our posterior implants. And so I did freehand for a long time. And now that I do guided, when I do go back and do a freehanded case, I feel like, that I'm a caveman, right? That I'm just going back in time, and it seems very cumbersome and inefficient, and it takes longer. There's just so much more to it. Now, granted, the students do learn a lot from doing some freehand cases, and so we do like them to do that, just in case when they're doing their guided case, if something goes sideways, they can fix it. But for the most part, we love the guided system that we have. So now here's another study looking at accuracy of guides. So why do we need to use a guide? So this is a randomized clinical trial, freehand versus guided dental implantation. All their surgeries were performed by two experienced surgeons. So, people who had done implants for a while. There were 207 implants of the same brand, same type, placed in 101 partially edentulous patients in both the maxilla and the mandible. 4 modes of surgery. And those 4 modes of surgery were freehand, pilot guide. And I would say that a pilot guide is, well, obviously it's 90% freehand. All it's going to do is show you where your initial pilot hole goes, which is not a small thing, still better than freehand. But after that, you've got to get all your angles just right. There's a partial guide where you use a guide for all of your drilling, and then you put the implant in freehand. And then there's fully guided, where you do all the drilling and the implant goes in through the guide. Okay, so those were the 4 that they looked at. Each surgeon did a pre-surgical plan of their own, so nobody else worked up their case. They worked them up themselves. Post-surgical CTs were then compared to the pre-op plan, similar to what we did. And the different things they measured. They looked at the angle of deviation. So angular deviation, in other words, how far off was that implant compared to their workup? What was the coronal global deviation? And obviously that's looking up at the crest of the ridge, the coronal portion. The apical global. So now how much was that apex off? How much was that crestal area off? And then they went through and looked at each one, and that's what we're looking at here. So if you look at freehand, pilot, and then partial and full, and you come across here and you're going to look at the mean for those angular deviation, you're going to see obviously that your full, even your partial to your full. In other words, if you don't put the implant in through the guide, you're going to have deviation, which is surprising, isn't it? But it's true. So more accuracy when you do full guided. Apical global deviation, similar. Your fully guided is going to give you the best result. Your coronal global, your fully guided gives you the best result. And then if you look at freehand versus guided, this one, I think this information is particularly interesting. So look, this is the maximum. So this was the maximum deviation that they had when someone was freehanding, 21 degrees, which is pretty significant. The maximum they had with guided was only 6. So quite a difference. And then here's your mean and guided. Mean improvement was about 4 degrees when you go guided. And then the conclusions of the study, as for the comparisons of this study sought to perform, it can be said that the static guided approach significantly improves the accuracy of dental implant surgery as compared to freehand. Furthermore, the results suggest that any degree of guidance yields better results than freehand surgery, and that increasing the level of guidance increases accuracy. So in other words, even if you do the pilot or the partial, you're still improving your accuracy. You're still going to get better results than you will if you do freehand. Patients who had experienced both computer-guided and conventional treatments revealed that they felt less pain and higher satisfaction with computer-guided. So, if you look at why we use guides, you can look at the doctor side of it. So we want things to be efficient, right? We want our day to work efficiently so we can get the most done in the time we have. We also want to provide good quality outcomes for our patients, things that are predictable, things that are going to last. And so after that, we have our patient to consider. What's going to be easiest for our patient? And that kind of goes back to the flap or the punch too, right? The punch is always better because the patient's going to have an easier postoperative course. Well, the surgical experience of the patient, whether they're using a guide or a flap, or whether you're using a guide or you're using no guide, freehand, the patient's experience is better when it's guided, and that's simply because it's more efficient and it gets done quicker. So the patients realize this and they appreciate it. Okay, let me just check my time here real quick and see how we're doing. So number 4, why slow drilling? So we do drill slow. We go at 100 or at 100 RPMs. I think you all know that, those of you who use DIOnavi. The question is, why do we go slow? Well, the main reason is these tolerances that I was talking about before. And the tolerances are the space between the drill and the tube and the guide, or the drill and the guide. In other words, when you slip your tube in, how much space is there between this outer diameter of the tube and the inner diameter of the sleeve? In these DIOnavi guides, it is very, very small. Same with the tube, very small. The drills go in, they fit tight. And those of you who use the system know that. They fit so tight that you can't get irrigation through the guide to the bone and to the drill. So in order to avoid thermal osteonecrosis, slow that drill speed down, and then you can go for a period of time before the bone heats up. Now we know that it's 47 degrees. That's what we need to avoid, right? We don't want to get past that. We know that once we get past that, we're going to start to kill off the bone cells. So we need to stay below that. So if you look at this bottom chart, what it shows you is if we're going at 100 RPMs and we start here at about 37 degrees Celsius, that we have about 10 seconds before we start to heat up. And we actually have more than that. But what we focus on is 10 seconds. I tell the students they have to count to 9 in their head or out loud if they want to when they're using a drill. They can't go past 9 seconds. If they get to 9 seconds and they're not done, they have to pull the drill out. We irrigate with the cold water. We give it a second or two, and then they can go back and finish the osteotomy. But we don't go past 9 seconds. You can see here at 1,000, if they hadn't slowed the speed down, within about 2 seconds, you're at 58 degrees centigrade. And so at this point, you're killing bone. So the drills go slow because we can't get irrigation in there. We can't get irrigation in there because tolerances are so small. And they're small because that's what gives us our accuracy and our good primary stability. Okay, so these are just different drilling times that may be required. And here's the other thing I want to make sure everybody understands is that this needle needs to be down in the osteotomy. I have students a lot of times, they're squirting up here. And I've no, you got to put it down in, and the water has to get into the bone. The other thing I would recommend that you do is refrigerate your irrigant and keep it cold. That does help a lot. And that whether you're irrigating this way or if you're irrigating with your handpiece and you're using a different system, it doesn't matter. I've always refrigerated my irrigant. And if you're not already doing that, I would recommend it. And then, of course, the other thing is always count to 9. Know how long you're in there. Okay. Number 5, why is the UF2 a better implant design? This was sort of an ambiguous question. So I wasn't really sure what they meant by better. Did they mean better than the old one, better than other types of implants? And since I wasn't really sure, let me just put it like this. I think that, if you look back all the way back to Brannemark and his implant design, the machined screw, and boy, what a great thing that he came up with the screw way back then. And I think because he was an orthopedic surgeon, he was used to putting a lot of screws in. And so it kind of made sense for him to design it as a screw. And then come to find out, decades later, of course, the screw is the best design. And we'll talk about that in just a second. But as the years went by, the implants continued to evolve and manufacturers would come up with new ideas, some of which worked and some of which didn't, right? We found out that cylinders were no good because the shear strengths were too great on them and they would fail. So cylinders were out. We HA coated them. Nope, that didn't work either because on that shear stress came, it would start to break off the HA. HA's out. And then, all these different things. We had a butt joint instead of a platform switch. We found out platform switching was better. So out goes the butt joint. All these different things over the years that were added that were found out to be good and those that were found out to be bad. The ones that were bad were put aside. So every time someone's patent would run out, then the implants companies would take that good thing that they found and incorporate it into their implant. Well, now here we are 50 years later. And just let me speak to the UF2 here, DIOnavi's implant. And I just want to kind of run through some of the things that they have on their implant that make it a good implant. This was another thing I was really curious about when I went to visit them in Heber City was the implant. I wanted to know about the implant. What's its composition? How's it designed? Why is it designed that way? because I had some good ideas in my head what makes a good implant, and I wanted to see if they could check the boxes for me. So let's start up here at the top, open thread. What does that mean? Well, we like to put our implants a little bit subcrestal, millimeter, sometimes 2, depending on where we're at. But that allows us to go subcrestal. We can't have one of these threads at the top. We need this guy, and we call that the plateau right there. So it has that, and that's important. And good implant systems have that. The upper threads here are tapered. What does that mean? Well, if you look at the thread itself, it's not flat. Do you see how the base of it comes down and it's sort of a taper? Okay, that helps with initial fixation. The other thing to notice about the thread is they're not sharp on the edges, they're flat. And there's a reason for that. That's so that when the force hits the implant, those forces are distributed properly into the bone. There's 3 types of force. There's compressive force, there's shear force, and there's tensile force. Tensile force and shear force are not good forces on an implant. Compressive force is what we're always after. In order to get compressive force, we have to have a certain design of our implant. And one of those things are a thread, so that we don't have shear force. A cylinder's bad. So we like the thread. That's good because the bottom side of here, that distributes the forces in a compressive manner. The flat side of this thread distributes forces in a compressive manner. And this flat side distributes forces in a compressive manner. So the thread design, yes, very important for distributing forces correctly. What about the body design? It's flared at the top. It's straight here at the body. Why is this body straight? And why is the whole thing not flared? If you look at a lot of tapered implants, they taper all the way from the top to the bottom. Theirs is tapered, straight, and then tapered again. Why is that? This allows for the implant to be inserted more true. Straight implants do go in pretty nicely. However, straight implants they don't self-tap typically, and if they do, they usually don't self-tap very well. So we like this apex, and we like them to cut and self-tap. But if they were straight, they would engage the bone in a more true fashion, and it provides for greater accuracy. So we like this straight portion. What about the apical design? Well, now it's got a nice taper at the bottom. That helps us engage the bone because it's self-tapping. It's got a great cutting portion right here. So you don't need a tap. Here's your tap right here. These edges right here, these edges right here, that's your tap. So it's going to cut the threads in the bone as you insert the implant. Okay, so it's got this great cutting edge. The bottom is rounded and smooth so that you don't have to worry about it injuring vital structures like the sinus membrane, of course, and the nerve or other things that might be in the area. It's got a dual Morse taper. Now, this is on the internal where you have your restorative things attaching. So you have a Morse taper here, and then you jump down and you have a second one here. And that really just helps you interface and ensure that you've got a good seal, and it helps distribute the loads better. And then, of course, you have a platform switch. Now that's the macro design. Okay, implants have a micro design and a macro design. That's the macro design. And to me, this implant does in fact check all the boxes for a macro design. I think it's got a great macro design. Now this is the older one. That's your UF implant, and here's your UF2. And you can see there are some. This was a straight taper. So now this one has the straight body, and this hole's all tapered. The other thing that's interesting about the new one is the micro design, which I want to show with you in just a second. Here's another image of how that body taper changes. And here's another good image of the dual Morse taper. So now let's take a quick look at the micro design. The micro design is really interesting. And as far as I'm aware, this is the only system that has a dual surface like this. So the surface itself is an SLA. SLA stands for sandblasted, large grit, acid etched. So there's a lot of different ways to develop a rough surface. Sandblasting has been around for a long time. It doesn't actually use sand. It uses a lot of different other particles, but it's like sandblasting that we all kind of think of, where these particles are blasted at an extreme speed and force, and it hits the metal and deforms it. Okay, and then there's acid etching, where they dip it into certain types of acid, hydrochloric acid, et cetera, and that etches it as well. But they etch it in a different way. The sandblasting creates large, gritty areas like this. And the acid etching does these small, smooth ones. Now, down here on the body, that it's both. So it's both sandblasted and acid etched because it provides a dual topography. It gives you these very large areas here where the surface is very rough. It's very rough terrain. But down inside that rough terrain, there's a second terrain, and it's very small, but yet it's very gritty. So you've got two types of surfaces within one. And that's really what makes the SLA surface so special, is that it gives you all of this surface area, and it really does help to improve bone formation onto your implant during osseointegration in a quicker fashion. Now, what DIOnavi did is they made their top portion, the portion that's up near the crest, it's only acid etched. So it only has that much smoother, smaller, gritty surface. And of course, the big reason for that, we all know, is that once this thing gets exposed, if you start to develop periimplantitis, the rougher that surface it is, the harder it is to treat, because those bacteria just love all these nooks and crannies to get into, and it's hard to get them out. So having this smoother surface at the top, this hybrid system, if you will, where we have the smoother system here and the rougher system on the bottom, is pretty unique to DIOnavi. Another really good feature that I like about it. And here's a good image of this on a microscopic scale that sort of shows you the different roughened surfaces and how they work. This just quickly shows you how the drills are designed with this 1 millimeter step so that we can get that 1 millimeter of submerged drilling that we like, and we can use that on this open thread. Okay. Number 6, what's so special about a UV implant? So I think we have to, if we're gonna answer that, we're gonna have to talk about photofunctionalization. And we'll talk about that, and I think we'll come back sort of a long way around to sort of explain. I'm gonna check my time. Long way around sort of on how to explain this to you all. So this is DIOnavi's UV activator. And when I have on here, I have on the screen, it's the activator, because in truth, it's not the implant, okay? If you get a UV implant from DIOnavi, it's a UV implant because of this, because of the packaging. It's a quartz ampule, which allows the light to enter and distribute through and onto the implant, and is in this photofunctionalization process. I can't get it, that's like a whole 2 or 3 hour lecture that I can't get into. I'm going to touch on it just very, very briefly to give you a little bit of understanding on it. But keep in mind, the implant's the implant, okay? It's the packaging and it's the activator that make the difference. Okay, so photofunctionalization, let's start at the electromagnetic spectrum. So we have our visible light. This is what we all see all the time every day. But then we have all these other things. Let's focus in on the ultraviolet light. We all know about UVA, UVB because we wear sunscreen all the time to try to protect ourselves from that. But down here, even lower, around 100, 200, is UVC. And that's the light that DIOnavi uses in their activators to activate the implants. Now, what is this photofunctionalization all about? So in a nutshell, when a new titanium implant is manufactured, before it's exposed to ambient air, it's cleaned, okay? It has and the first thing that develops is a titanium oxide surface, which is important to osseointegration. And the implant at that point it's perfect, okay? It has no hydrocarbons on it. In other words, no organic debris from the ambient air, the atmosphere. It's hydrophilic, and it's electropositive. It has a positive charge to it, okay? Now, once that implant is exposed to the ambient air, so in other words, it goes into a package, it goes onto a truck, it comes to your office, it sits on a shelf. During this time period, the organic matter within the air, specifically carbons, hydrocarbons, are deposited onto the surface of the implant, and they cover that titanium oxide layer. Okay, what that does then is it changes all the biological characteristics of that implant. And it doesn't osseointegrate as well. And the bone implant contact, in other words, the amount of bone that you get that attaches to that implant is less. And you look at studies, 50 to 60% of bone contact to an implant is considered successful, and that's osseointegration. Only 60%. You would think that, all around that implant, it's just covered in bone, 100%, and it's not, right? But we have to wonder why not. That's weird. It should be, but it can't be because of these hydrocarbons. And so some researchers started looking at UVC light because it's used for so many other things in industry. They thought maybe it would work on here. And so sure enough, they UV treat this implant. It removes these hydrocarbons, this organic debris, and then it returns it back to its natural state just when it was manufactured, and it exposes that titanium oxide layer. So now it's hydrophilic, super hydrophilic, if you will. It's the correct charge again. Now it's positively charged. And why is that important? Because all of the proteins that are in our blood that are responsible for attracting the osteoblasts to the surface of the implant, they are negatively charged. So if your implant's negatively charged and the osteoblast and the fibronectin and the albumin have the same charge, they're going to naturally repel. They won't be drawn to each other. So if we can get the implant back to the correct charge, now you have a positive and negative. They're drawn to each other. And what research has shown is not only osteoblasts drawn to it, they will migrate to it more, yes, but you'll have more, they will proliferate more, and they'll be of a larger size. So that's why they call it, that's why we say that we're returning it to its bioactive state, because now it's going to integrate, it's going to act with the patient's biology to better integrate to the bone. So that's what that's all about. So when you say, what's so great about a UV implant? The implant? Nothing. It's the same as the non-UV implant. What's different is how we activate it, how we clean it, so that it's now bioactive, and it now is going to interact better with the patient's biology. We're going to get more bone implant contact. As a matter of fact, one recent study that just came out showed that they got up to 90% on certain areas of the implant covered in bone if we treat them. We do use the activators, and we UV treat all of our implants at the university, and it's been allowing us to restore them at 8 weeks. Because not only do we get more bone implant contact, we get it faster. And there's some other stuff I could show you about moving the curve and all that, but we don't have time tonight. But just look at this slide, and it'll show you when the surface is hydrophobic, it's like oil and water, right? They don't mix. And that's kind of what this is like when you have a hydrophobic surface. Your blood just doesn't mix with the implant. When we turn it to a hydrophilic surface, it does. And now we have this blood just penetrating all those nooks and crannies that we saw on those previous slides. And now you're going to get better osseointegration. Number 7, the implant does not go to depth. What do I need to do to get it to go further? This one's pretty easy, and I hope I'm answering your question. So here's our master kit. And we're going to go through our normal steps, your tissue punch, your bone flattener. Then you're going to put your tube in, you're going to do your 2.0. And then you're going to come over here and you can either use your 2.07, or you can go ahead and go on and start using your drills. Now, let's say that your drilling protocol told you that you needed to go to a 3.2 by 11.5, let's just say randomly. And you go to seat your implant. You put your implant in. Now, I don't know about you, but when I'm doing flapless, and I'll tell you, I was when I first started doing flapless surgery, I was a little nervous about it, because when I flap it, I can look at it and I know for sure it's right where I want it. So what I started doing to make myself feel better is I'd put the implant in, I'd get an x-ray before, take the guide out, I'd get an x-ray, I'd do a vertical bite wing, which is what I'd recommend, because with a vertical bite wing, you're going to get that 90-degree angle that you need. So there's no distortion. Don't do a PA. It's not going to show you anything accurately. And who cares about the apex right now? Right now, I want to know, where am I at with my bone level? So I'll take a PA. And yeah, I understand exactly what you're saying. Sometimes it's a little high. And I go, oh, it's not deep enough. So what do? Well, it's easy. You just go to your next drill and then go down. Now, of course, that all depends on what's down there, right? If the nerve's there, you can't do that. If your sinus is there and you're not doing a sinus bump, you got to want to be careful there too. So that might be an instance where go to your implant stock and get a shorter implant. Okay, so if your anatomy is limiting you to going to a longer drill, then go to a shorter implant. That would be my recommendation. Okay, I hope that answered that question. What makes DIO guides better than others? I talked about this earlier, so I'll move through this one quickly because I'm burning up our time rapidly here. So what about the surgical guide? Why is it so great? Well, they do. They make all their own items, including the material that they pour into the printer. They have their own software that they use. And this thing's really cool. This is their printer, the DIO Probo Z. And it's pretty neat. There's some cool videos online that you can go watch. This is their cure, the DIO Probo Cure 2. This is where they cure their items. And this is actually off of a presentation that I put together for our faculty at the university when we presented the findings from our 20-patient trial that we did. Because trust me, I got questions just like this. What's so great about these guides? And so I said, I put these on there and I go, well, look, these are the ones we've been using. Look at that. Clearly better. It's very robust, meaning that there's no flexion. It will not flex at all. These guys, you could just take in your hand and they would bend. So any kind of pressure in the wrong spot is automatically changing the angle of your drill. So now you're entering inaccuracies into your case. Look at the size of these windows. The windows are beautiful. You can easily look and see if the teeth and the guide are right up against each other, or are there gaps? But you can just tell the quality of the guides are good. Why else are the guide good? This isn't going back again to some of the stuff that we talked about. So this is an example of a different guided system. And there's no tube here. It's just the sleeve and it's just the drill. So you may wonder too, it's like, why are we using this tube? And look how long the tube is. Why is the tube long? Well, because the closer we can get to the bone before the drill engages it, the more accurate it is. The further away you are, the more chance you have of this happening. And I tell you, it does. I had to do a case again a couple of weeks ago with a different implant brand with that one of those guides I just showed you, and I was showing the students the difference because they had done some DIOs with me too. And I showed them this, and I put the drill in it, and I moved it. I'm like, look what you can do. You're going to have to be really careful that you don't introduce any variance in your guide, because it would take very little movement for you to do that. So the thickness and the sturdiness of that guide is important so that there's no flexion and that there's no error introduced into it by us, by our hands, our wrists, us being too heavy-handed. And these tubes are awesome because they get you right down to the bone. So when you engage the bone, there's no error, there's no movement. It's spot on. And this is a great example. I love this. This is talking about different offsets, but just the fact that when you're closer to the target, you're always more accurate. We all know that, but it's just great to look at and go, yeah, you're right. So this is what DIOnavi does. They get you closer to the target, so it's going to increase your accuracy. And these are those tolerances that I was talking about earlier. This is the difference between the tube and the sleeve, 0.01 millimeters. And here you are down here, 0.1 millimeter. But these are just very small tolerances that add up to less than 1 degree of variance. Very small. And these are their offsets. And this is a good thing too to think about with their guides, is that they're about the only, I think that they may be the only company that I can't say that for sure, but I think they may be the only company that has a 9 millimeter offset. And that's kind of their default, except for the narrow kit, which is always 12. But the 9 millimeter offset is always getting us closer to our target. You know, there's some that has a standard of 12, that's always 12. So the further you are away, the more chance there is for an error. So I like the fact that they're always getting you as close as you can. And then here's looking at some different studies over the years about how accurate different types of guides are. And so, you know, this is 2009, 10, 3, 5, 9, 8. And then this is what you get when you use DIOnavi. As you saw, it was like 0.0857, so 0.9%. So the accuracy with their guides, at least in my experience, and I think the research would bear it out too, it's pretty good. Oh, I misspelled immediate. Sorry about that. Number 9, immediate provisionalization. So somebody wanted to know about doing an immediate provisionalization in the anterior maxilla. Well, I have to tell you, it's pretty simple, especially if you're using digital technology. With digital technology, you can, and I'm going to run through it with you here real quick. So let's just do that. I get ahead of myself sometimes. So this is an image from one of our hands-on courses that we do, and it kind of gives us everything we need. So this is a narrow case. So you have a narrow kit. You have your guide, of course. You have your abutment screws. These are your jigs, and then this is your implant. Okay, so the narrow system, as I mentioned earlier, it has a long offset of 12 millimeters, and that's because of tissue thickness and some other reasons. But it does provide us with some accurate drilling in narrow bone, which is typically where we're putting these. And the immediate restoration based on an accurate implant placement can't be overstated. But let's look at these images real quick. So here's your pre-op. Okay, so preoperatively, you're going to scan your patient, right? So you're going to do a full arch maxillary scan, a full arch mandibular scan, and you're going to get a CBCT. Okay, you're also going to need a buccal bite, which you scan as well. And that's going to allow the technicians at DIOnavi to, at Whitecap, to merge your images together when they do the planning. And I kind of skipped all those steps here because I just kind of wanted to show it to you in a nutshell. But here you are preoperatively. The tooth's missing. You've done your scans. You've done your CBCT. You've sent the images to the Whitecap. They've sent you their workup back. You approved it. You do the surgery, and now your implant's in. Now, when you send all your images to Whitecap, in the workup that you fill out, you're going to tell them that you want to do a provisionalization. There's also a place for you to give them the shade color. Now, they do most of all this in just polymethyl methacrylate, PMMA. And that's fine, I think, for a temporary. They turn out very nice. But that's all you need to send them. With the digital data sets that you send them and give them the shade color, they can send back to you what you need to go ahead and put in your temporary that day. Okay, so recommended torque value if you're going to do your immediate provisionalization is at least 35 Newton centimeters. That's pretty standard. This is sort of what it looks like when we do this in class. You have a model, and the abutments are already in place, as you can see, and so they will fabricate a jig on those abutments for you. And here's your anatomical design. So this is what it looks like when they merge everything and put your occlusion together. Then they're going to go ahead and they're going to design the fixtures for you. And of course, this is all based on the previous implant planning. They're going to develop your guide based on the ideal restorative position of the restorations, not on the bone. And then they're going to send you a drilling protocol. You're going to go through your drilling protocol. You'll place your implant, and then you're going to go ahead and place your abutments with your abutment jigs. That's what these are. These help you to keep the abutment from rotating while you're tightening down your screw. And then you'll affix your provisionalization. And I hope that helped to understand it. Again, 5 minutes isn't a lot of time to go over that stuff, but if that's something you're interested in doing, we do have some good courses for that. It's a one-day hands-on course, then you'll get to do that on several different models. Okay, last question. How do we prevent and treat sinus perforations? Well, the best way, to prevent in this particular scenario with the DIOnavi's sinus bump system, just going to check my time, is on your approach. Okay, so again, careful planning, accurate data sets. Now, and I haven't really brought that up yet tonight, but I want to stress that your guide will only be as accurate as your data sets. Now, they will kick them back to you. If you have a scan error, they're going to kick it back to you, and they're going to want you to give them one more accurate. And I applaud them for that. Okay. You've got to get good at evaluating your scans and knowing that there's a scan error, a merge error, that there are problems with it, and not just your IO scans, but also your CBCT. If a patient moves in the CBCT, there are ghost images, and it will tell you that they've moved. You need to repeat the CBCT. Your results will only be as good as your records. It's no different in analog than it is in digital. If your impression's bad, your crown's not going to see. Same thing. If you can't provide good data sets, your guides won't be accurate, and you're not going to get good results. So accurate data sets are going to provide an accurate workup that's followed correctly by us. In other words, if we follow our drilling protocol correctly, and to me, this is the approach, right? We're approaching the sinus until we reach this step. Now we're entering the sinus. And we have to be good on our approach. Okay. We have to make sure that we're following the steps correctly. I have heard people ask before, do we have to use all the drills? There's so many drills. I insist that we use all the drills. I think it's important for all the reasons that I talked about earlier. I do insist that we do that. You're a doctor. If you choose to skip drills, that's up to you. I would recommend that you don't. It doesn't take a lot of time to do these cases. They're very efficient. And I think for the little bit of time you save, it's not worth the potential risk for complications that you might incur. So your approach has to be careful. So on the approach, and then when you reach this one, this is when we want to make sure that we get in. I will warn you, if you've not done a lot of these, that these steps right here are difficult because it goes at a very slow speed. If you look down here, they're only at 10 RPMs. And these are not end cutting. These ends of these burrs are smooth and round so that they're protective of the sinus membrane. So you got to put some pressure on these. And if you do, you're counting to 9. And when you hit 9, you're coming out, you're irrigating with cold water, and then you're going to go in again after that. So yeah, a lot of force, but for no more than 9 seconds. Once you've got this down to the sleeve and you're in, then you're going to go ahead and you're going to gently lift your membrane. There's some, again, we do this in the DDA course, the day-long course that we do, and hands-on, you'll get a chance to do this on a model, and you'll see how easy it is. Once you've done that, then we have to go in and completely open the opening so that we can then put our graft in and then eventually our implant. Now, when you inject this, that's another opportunity for you to be cautious with your membrane. The drills themselves are built to be cautious. The sleeves and the workup prevent us from going too far in. So that's caution. But how harsh and how much you inject in there, you need to be careful about. Now, part of it depends on how much of a lift you need as to how much you put in. And we have a chart for that you can look and see how much do I put in. So if you're doing something small, I did one the other day that was only a few millimeters, and I put in about 0.5 to 1 cc. Very carefully, just a little turn and a little push, little turn and a little push, little turn and a little push. And then when I'm done, I aspirate the contents back, and I want to see blood and fluid come back up my tube. And if it does, then I know my sinus membrane's intact. So I'm happy. Well, then you ask, what if it doesn't come back? Good question. You can perform a Valsalva maneuver to find out if there's air moving in and out. If the Valsalva maneuver is positive and there is air moving, I would not suggest that you place bone into this osteotomy, for the simple fact that if you put bone in the sinus, it will get infected 100% of the time. And that would be hard to defend in court, or in front of the board or anyone else for that matter. If it's a small sinus bump, 1, 2, 3 millimeters, and you have what you believe to be a sinus perforation, don't put any bone in, but insert the implant. We know that an implant can be within the sinus within a couple millimeters and cause no harm. There's been studies done, many studies done over the years to prove that. And we've all seen patients come in that have implants in the sinus and they've hurt nothing. So we all know that's true. Now, I would not recommend that you put, 7 millimeters of an implant in the sinus intentionally. Um, in that case, you might want to allow it to heal and then come back and repeat the procedure another time. Okay. So this is looking at your how we determine this height, the offset, the residual bone height, the anatomical depth is measured by CT scan. And again, we just don't have time to get into all of these. But what I wanted to show you was that it is possible to incrementally increase your depth by changing your stoppers. Okay, because every once in a while, what'll happen is you'll do your second sinus drill, you put your water on, you try to inflate, or you try to expand your membrane, and it's just not going. And you aspirate nothing. And so in that case, in my experience, I'm short of the sinus floor. So what I'll do is I'll change my guide or my stopper, and I'll go another millimeter. And then I'll try my fluid again, my saline again. But this is just one more way for you, sort of like we were talking about before, or hey, I didn't get my implant in all the way. What do I do? This is the same sort of thing. Gosh, I'm doing the sinus lift. I can't get the saline in. What do I do? You just need to go a little deeper. You're just not quite deep enough. So add 1 millimeter by changing your stopper. This is a nice video to kind of show you. It's just a little twist and a little turn. And you can see there's just not a lot of fluid going in there. And now they're aspirating and you can see the bloody fluid come back up and out. So that's what you want to see. Sinus is intact, the fluid's back out. You're good to go with your bone graft. Okay, so this is what I mentioned earlier. You don't always need bone. So if you're less than 3 millimeters, just put the fixture in. Don't worry about the bone. Now you can put bone in if you have a good aspirate like the video just showed. Sure, go ahead and put your bone in. You can certainly do that. But keep in mind what the bone's there for is to maintain space for your body to make bone. Okay. So if you have a big lift, you need bone to maintain that space. Otherwise, the sinus membrane is going to collapse and your body will not be able to fill that space with bone. So bigger lift, you need bone to maintain space so that your body can make bone. In a little space like this, a blood clot is plenty for your body to make bone. Okay. And that's been known for a long time that with minor sinus lifts, we didn't put bone in. So little lift and you're not sure about the integrity, just put the implant in, don't worry about the bone and you'll be good. Okay. Greater than 3 millimeters, you're going to want to put some bone in to maintain space. This is just a quick look at what they should look like postoperatively. This is a CBCT. This is one of the ones we did during our trial. So I got a CBCT of it. And so you can see from both angles that you want to see this nice dome shape. If you have a nice dome shape, that tells you your membrane's intact and that everything should be good. And this is what you want it to look like postoperatively. Okay, that's excellent question. That was one of the ones I was wondering if someone would ask. So I just had a consult like this yesterday. And the patient didn't have adequate keratinized tissue. And if we did just tissue punch, we probably would have punched keratinized tissue as well as mucosa, which we don't want to do. So what I told the students we do is we're going to lay a flap and we're going to do the procedure like we normally would, put the healing abutment on, and then we'd suture it up. So if you don't have adequate keratinized tissue, you've got to flap it. Yeah, because you've got to preserve that keratinized tissue. You have to have at least 3 millimeters around it. More's better, but minimum of 3. You can't have mobile tissue. You can't have unattached tissue. Okay, so the question is, I didn't get the implant in and I had to take it back out. Should I put the same one back in again? Okay, yeah. So it takes some time for the hydrocarbons to form. And I've done this quite a few times where I've taken it out and worked on the osteotomy and put the same one back in again. So for it to be out for 5 minutes or something while you work on the osteotomy and then replace it, it's fine.